Thank you very much. And I see the timer now. Maybe just put it here so we can actually see it, because there is a bit far away. Yeah, that's better. Thank you. So thank you very much for inviting me over. Since Dr. Paredes has already covered pretty much the background of this pathology, I changed this slide and I will just give a quick background to what we've done. We've done 2 cohorts as a follow analysis, 75 long COVID patients and 75 healthy controls. From these patients, we've analyzed quite a lot of variables. Our database has 800 variables per patient. 300 of them are biomarkers, so it's quite an extensive analysis. And the remaining ones are basically all the socio-demographic and quality of life and symptoms and acute symptoms information. This, the information I'm going to show now is unpublished, so of course feel free to take pictures, but the paper will come in hopefully a few months. So when we talk about quality of life, we basically want to compare long COVID and acute COVID. Where does the persistent symptomatology appear? So this is a cross-sectional study with the population I just said, and we use the SF12 to measure the quality of life. And then we obviously the symptom analysis and socio-demographic factors. These are the key variables that I chose for this study or this article, this paper, this publication. And this is a very brief summary of, and also quite basic. Obviously, the persistent COVID, the long COVID patients have a worse quality of life. And the cognitive symptoms play a big role in this. We perform multivariable regression analysis, and mainly we want to talk about clusters. How do these symptoms, when they appear, and their intensity, what role does this play in dividing patients into their cohorts, into their clusters, sorry. So mainly, this is obviously quite, again, because the sample size is not that big, it's quite robust, but I mean, 170 patients doesn't allow for much. But we get 2 main clusters. Obviously, the silhouette scores allows for more clusters, but the optimal one is with 2, which is the one we took. In the right, we see the clustering results. Again, quite obvious, quality of life is a lot, is worse in the COVID, which is the blue, the long COVID, which is the blue one. We then, with this cluster analysis, I'm not sure if I have a pointer here. I don't have a pointer. It's fine. The cluster profiles, well, it's fine. Don't worry, it's fine. Just take it out. Basically, what this represents is how much of a big role do these different variables have. Myalgia frequency, myalgia intensity, myalgia duration, and the same with cognitive. So which of these factors play a bigger role in worsening the quality of life of patients? When we do the cluster analysis, we have to refine the results, because when the sample size is not that big, we have to be careful with outliers, with the thresholds for these variables. When we talk about myalgia duration or cognitive symptoms, we talk about frequency, and in frequency we divide into high frequency, low frequency, medium frequency. This obviously plays a big role in separating the patients into all the clusters. And this plays a role in the clinical care we have to give and where we have to be quite observant and active in taking care of our patients. So that means, okay. The predictive factors, which is, with this logistic regression, the most influential ones. Variables such as fatigue duration and cognitive symptoms, the quantity of symptoms. This is what is meant by cognitive symptoms, are the ones that play a bigger role. The model performance was quite accurate, again, because of the simplification, this quality of life, of course, is going to be an accurate model, because the quality of life is obviously worsened. The sensitivity analysis performed on this cluster to test the robustness showed that, again, myalgia and cognitive functions show a very high robustness when dividing the patients into worse or better quality of life. Cross-validation was also carried out because we have to ensure that these models perform well on unseen data. Obviously, when you have so many variables, you're going to lose some of them. Patients, there might be some errors or some loose data, or they cannot perform some of the cognitive tests because they are just too tired or not unable to perform. So you have to take this into account. But cross-validation was carried out, and the accuracy and standard deviation showed that it was a pretty accurate model. Why is this important? Because there is a huge need for validation of these symptoms and its relevance in the pathology. Why? Because patients are still not taken seriously. Patients are still having to go to work, having unpaid job leaves, and still, even though we've researched a lot apparently in this room, patients are still coming now to us with still all these problems unsolved and untaken care of. So this heat map, I'm just seeing that the heat map is the one on the left and the forest plots is in the right, show again that the fatigue duration and the cognitive intensity, as you can see, the red ones were the one, the red one with the 1 are the most important and the most relevant into classifying the patients into a worse quality of life. Again, there's a lot of symptoms that we took into account, a lot of sociological and psychological aspects, and I chose myalgia and cognitive because they were the ones that the ones that easiest divided the cohorts. This is the decision tree for the cluster prediction, which, yeah, you can see pretty well. Again, in the left is the myalgia duration. This is the decision tree that we can use to predict where the patient is going to land. If the cognitive duration, for example, is less than 0.23 in the mean deviation, of course, and the myalgia duration is also less than that, you go into the next step, which helps to build more clusters and specify into which ones these patients belong to. I'm just going to skip because there is not much time. The one, again, no surprise, the cognitive duration was the one with the highest, the HVIF, the variable inflation factor. But even though this, the cognitive duration may change or have may variate a lot among the cohort, it doesn't really matter for the model, and still the prediction is successful. Again, when we redefine the threshold for clusters, I said low, medium, or high intensity on the cognitive intensity, and the same with the myalgia. We still get, again, both 2 clusters, but patients are still stratified. And, well, these are the interactions: cognitive intensity and cognitive frequency. And their effect on, in the left, you get the myalgia frequency. This means if the cognitive intensity is higher, it's going to have a bigger impact on how the myalgia frequency worsens the quality of life. And in the right, we see how a higher cognitive frequency, cognitive symptom frequency, is going to have a higher impact on how the fatigue duration affects the quality of life. So again, cognitive intensity and frequency show a clinical or a treatment goal. This is a summary. You can take a picture. I'm not going to go over it that much. But again, the key predictors, the cognitive symptoms, the fatigue duration, and the myalgia symptoms, the frequency and intensity. And those interactions between cognitive and myalgia frequency, the cognitive frequency and fatigue duration show a good therapeutic approach. The key predictors for the cluster, membership, and quality are here. I'm just going to skip over because I almost have no time left. The discussion or my suggestions are that we need bigger sample sizes. Again, when we talk about prediction models, when we have only 180 patients, that's not much. It's good, and it's a good sample, but it's not enough. We need to standardize how we measure quality of life and all these symptoms. We can't all just be using different questionnaires to get the variables because the methodology there falls to the ground, basically. And what's been shown, obviously, not yet methodologically proven, but continuous emotional and physical support and rehabilitation for patients is quite effective. Obviously, as we talked before, or the colleague here said, how the patients perceive their pathology or their illness plays a big role. Not to say that the illness itself is not important or not existent. It's still there. But how they relate to it is quite important. Also, this is the first big paper we have published, which is not related to the quality of life, but this is a characterization model we've done based basically on immunological, biochemical, and cytokine markers, with, again, quite a big prediction and sensitivity and sensibility. And what's great is we are now doing the follow-up of all these patients. We're expanding both cohorts, the controls and the long COVID. We want to go from 85 to 120 or 150. And also, we're going to add a new branch with fibromyalgia patients. Why? Because as you all probably know, the symptoms, the way they present, is very, very similar. So we want to see how maybe the etiology might compare. Thank you very much. If there are any questions, this is my email and my LinkedIn, and thank you so much.